Good afternoon. Welcome back. We are covering the respiratory system today. The respiratory system is broken into two video lectures, and a lot of these are pictures, so you may definitely want to make use of the ability to take notes if you want within Nearpod, or just pause the video and take notes on paper, whatever works best for you. So without further ado, I'm going to go ahead and I'm going to hit my my pointer, and I'm going to go ahead and move forward in the slides. So the respiratory system has several functions. First and foremost, we know that it's there to provide an area for gas exchange. We know that it's going to provide the ability to move air into and out of the lungs. We have a way to protect surfaces from dehydration, temperature changes, and pathogens. It allows us to permit or produce sound and speech and olfactory sensations. And we're going to take a look at the respiratory anatomy. So I'm going to break this down. So let's take a look here. Some of the major structures that we want to look at here with the gross anatomy. You do have the trachea that comes down and it bifurcates. That's a big fancy medical term for, hey, it splits into two. So it bifurcates into two of these bronchioles. You have the right and left main stem bronchus and breaks down into bronchioles. The point at which it bifurcates, so this area right here, does anyone know what that term is supposed to be? If you said the carina, you would be correct. So the carina is the point at which the right and left main stem bronchus bifurcate or split. Now you'll note that here on the right lung you have a total of 3 lobes. You have this upper lobe here, you have a middle lobe, and then you have an inferior lobe. And unlike the heart, which is flipped, the apex is the top of the lungs and the base is the bottom that comes in contact with the diaphragm. Now on the left side you only have 2 lobes. If you were ever curious, or if you want to pause the video and think about this for a second, why does the left lung only have 2 lobes in comparison to the right lung? Now, if you came up with the answer that your heart sits over there, so it has to provide a little bit of space, you would be correct. So that heart doesn't sit directly underneath the center of the sternum. It actually sits off a little bit to the left. And as a result of that, that left lung is only going to have 2 lobes. The other thing that I want to point out here too has to do with this right and left main stem bronchus. If you take a look, that left main stem kind of has more of a offshoot, whereas the right almost goes down a little bit straighter. This kind of goes off at more of an angle, so it comes down and then it shoots off sideways almost, whereas the right goes straight down. So when you're working on intubating your patients and you're intubating or using the tube to intubate them, if you should extend the tube too far down the trachea, you are more likely, and I say more likely with an asterisk because I knew a medic that not only did it once but did it twice in their career, you are more likely to have a right main stem intubation than you would a left, because of the way all of that has to kick out and shift in order to make the space. So this is why when you're checking or assessing for lung sounds, when they teach you about intubation, you want to assess over the stomach first, and then you go to the left and then to the right. So that's how you're going to assess for lung sounds. And we want to take the chest wall and we want to split it and we want to look down in. So we're peering down in and we're peering just above the heart. So you're kind of looking in. You can see the vertebrae back here at the back, and we're looking down inside the body. So as you're looking here, you're going to see a few structures. First and foremost, I want you to take note that you do have this section here in the middle that separates the right lung from the left lung. The section that splits the two lobes of the two lungs, pleural cavities, if you will, is the mediastinum. And within the mediastinum, you're going to find the heart, the great vessels, there they are. You're going to find the thymus, which sits just above the heart, and you're going to find like the esophagus, which is what you see here. That's leading down into the stomach and into the small intestine. Now, some other structures you'll see. You have the pericardial cavity. Remember, you have a visceral and a parietal. So with the heart, it's going to be a visceral and parietal pericardium. With the lungs, it's going to be a visceral and parietal pleura because we're dealing with the lung tissue, so it's called pleura. Now remember, the visceral touches the organ, the parietal touches the cavity, the body cavity itself. So we're looking at the parietal being back here. Okay? And in between those two layers, you do have some fluid. So if you have ever experienced pleurisy in your life and you felt like every time you breathe you had severe chest pain, it's because you actually had an infection in between the visceral and parietal pleura, and it was caught every time you try to breathe, it's rubbing past that area of infection. It's very painful. Same thing goes with the pericardial cavity, which we're not as concerned about this time, but you can have pericarditis where you have the inflammation in the pericardium. That's the same kind of concept. Now, when you take a look at the entire respiratory system, we're going to start up here at the top. And there is a certain point at which your ability to get food through the GI tract is going to be the same as that used in the respiratory tract. So if you're taking in food, you're bringing it past the teeth, you're masticating the food. That means you're chewing it up, you're turning it into a food bolus or chyme, and you're going to swallow it. And when the tongue swallows, it literally pushes off the top of the mouth, the roof of the mouth, and that forces the food to fall backwards. What happens here, the uvula is the little hangy ball down at the back of the throat. If you go and you look back there, you get the little hangy ball. That's your uvula. That uvula, when the tongue sweeps up and pushes that food back, it's actually the muscle will actually shove that uvula up. So that is what prevents food from going up and out the nose. If you've ever laughed at the wrong time while you were swallowing and you had pop come out your nose or anything like that, and you're like, that was because when you laughed, you were spasming your uvula and it didn't shut off completely, and it actually caused the food or the water to go up instead of going down. So there is this part where you're actually not only using this airway for the purposes of the respiratory system, but it is also in conjunction with the gastrointestinal tract. All right, so up here in the nasal cavity, you have the nares. That's the opening to the nose. And inside the nose, you have these nasal conchae, and sometimes they're referred to as turbinates, because what they allow that air to do is as it comes in, it will turbulate, it turbinates, it allows that air to kind of tumble and move around in here, and when it does, it picks up moisture. So that helps us. Picks up the moisture, it grabs any debris that's coming through, and then it's going to pass down through the back. So you have the nasopharynx, which is back here, and then you have at the back here, you have the oropharynx, and those two are collectively referred to as the pharynx. So you have the nasopharynx, the oropharynx, or you can just call them the pharynx. And it's going to travel. Now, of course, your food is going to travel down the esophagus, which is posterior. So if you looked at me sideways, you have the trachea here. Yep, you have the trachea. Make sure you guys can still see me. But you have the trachea on the front. Behind that trachea is where your esophagus is going to sit. So if everything fares well and that tongue does what it's supposed to do, and you're swallowing your food and that tongue is moving up and back, that actually, because it's attached here at the back, what do you think this structure is right here? Anybody got a clue? This is your epiglottis. So if it attaches and does what it's supposed to, the movement of the tongue will cause that epiglottis to close and shut to protect the trachea. So if you've got food coming in, it's going to pass the only place it can go, and that's into the esophagus. You do have, and I'll show it to you, I've got another picture, I'll show it to you later, I'm not going to get into it right now, but this structure right here, where you're including that Adam's apple, which is the more prominent area for men, but you've got that larynx, and it includes everything here from the point of the epiglottis down to that first ring of the trachea, that first round ring. Now you're gonna advance down. You're gonna advance past the trachea. You do have your right and left main stem bronchus. You get that little point, which is called the carina. And you're going to have these bronchi, these right and left main stem bronchus, and they're going to slowly start branching out into smaller and smaller bronchioles. Sometimes you'll see textbooks refer to these as primary, secondary, and tertiary bronchioles. They're just getting smaller and smaller and smaller each round. These bronchioles will terminate, they will stop in a bundle of grapes, also known as the alveoli. The alveoli, if you look in this picture, you'll see that the bronchioles and the alveoli have these little bands wrapped around them. Those are your little muscular, smooth muscle bands. These are elastic little bands that allow the alveoli that when you inhale and they get big, when you exhale, they will help with the recoil. So that's what those are for. So in conditions like emphysema, those elastic fibers that sit around the alveoli become wore out and they lose their recoil ability. So it's like that worn out rubber band, that stretched out rubber band. That alveoli gets stuck in that big wide position, which is why those patients have barrel chests, because they cannot get the alveoli back down to their normal size. Now, surrounding each alveoli is a capillary bed. And the capillary bed doesn't come in direct contact with the alveoli. It actually there's a little bit of a space. And that's where you have the ability for the gas exchange. Because remember, your capillaries and your alveoli are only one cell in thickness for each. So it allows for an ease of gas exchange, provided we don't have any disease pathology to bother that. So those are just some major structures. The other thing that I want to point out too with your alveoli is you actually have about half a tennis court if you were able to take all the alveoli within the lungs and splay them out flat to where they weren't rounded. If you were able to splay them out flat, you would have about half the size of a tennis court for gas exchange to take place. I think that's pretty amazing to be all wrapped up in this one little chest wall, to be able to lay it out half the size of a tennis court for gas exchange. It's pretty daggone cool. Oh, and one thing I didn't mention on the other one, of course, you do have your diaphragm, so we can't forget that. So let's take a little bit of a closer look or an inspection of this upper airway. So we're looking at the upper airway right now. You have the nares, which are your nasal, your openings to your nasal cavity. You have those nasal conchae or turbinates. And like we said, you start getting back here, you're starting to look at the nasopharynx, okay? And then once you get back here, you're in the oropharynx. So you'll be able to see the oral cavity. You can see really well here how the musculature of the tongue is directly tied in with that epiglottis, and that's really important. Now there's this little space back here that's kind of nested, looks like a V almost, if you will. What do you think that space is called? Does anybody have any ideas? If you guessed the vallecula, you're correct. So why do I care about some random name that's not even on the slide? Because what you're going to find out is you have a straight blade and you have the curved blade when you intubate your patients. The straight blade is designed to specifically designed to go in, and it will pick up the epiglottis. It actually will come up underneath the epiglottis. It will touch right here, and it's going to pull the epiglottis up and out of the way, so it exposes the vocal cords, which are really hard to see in this picture because it's a side cut. But the curved blade, which is also known as the Macintosh blade, that Macintosh blade is curved. It will sit in the space known as the vallecula. It sits right here. So when you actually connect with it, it sits in that vallecula and it pulls the muscle tissue up, which is going to inadvertently bring the epiglottis with it. So there used to be this big thought process that one was more superior than the other, and there's a lot of different factors that come into play as to which one's going to be the best bet for you. So don't fall into that trap. Find what works for you and stick with it. I will also tell you, and this is something you'll see in the lab when you start working with the instructors, sometimes one blade tends to work better for you than another, but if you go to work on a human being, an actual physical body with soft tissue, you'll find that that other blade may be more effective for you. But the Macintosh blade was considered superior to the straight blade only because it went in and touched the vallecula and pulled it out of the way. It wasn't kind of jamming down in there and causing tissue damage. I don't think it's quite as ridiculous as they said it was, but that was the thought process behind that. So we're going to move back here. Again, you have the hyoid bone. It's the one free-floating bone that we have in our entire body. You do have that space, remember, that goes from the level of the epiglottis and it extends down to the cricoid ring, that one single cricoid ring. That comprises your larynx. You have the opening here with the vocal cords. We're going to see that in another picture, in the next picture, actually. And you do have that thyroid cartilage. We did show this in a previous video. You have the thyroid cartilage. That's really that Adam's apple. It's really super prominent on men. And right beneath that thyroid cartilage is a little tiny space, and then the cricoid ring. The cricoid ring is a solid ring. It's the only solid ring. The rest of the trachea rings are C-shaped, and we're going to discuss that here shortly. But when it comes to the cricoid ring, in children, because children haven't grown and gotten real tall and stretched out, that cricoid ring represents the narrowest point in the airway. So the airway of children are cone-shaped, with that cricoid ring being the smallest point. Now imagine you're a kid and you like to check things out and you put things in your mouth when you shouldn't. If you accidentally swallow something, it's going to go to the lowest point because it's made to do that, right? That cone-shaped, it looks like that. Now, as you grow and you become an adult, things start to straighten up and become more rigid, solid. And that's the difference between the adult versus the pediatric airway at that cricoid ring. Now this slide is where we're going to talk a little bit more about those structures. Sorry, I had to pause for a second. I'm blowing my nose. All right, so again, with men, that Adam's apple or that thyroid cartilage is the really prominent area. You can see that hyoid bone, that's the one that's free floating. The epiglottis actually sits behind it. So if you're looking, this is an anterior viewpoint. This is the posterior. So that's what it looks like a leaf. It's a leaf-shaped structure. This is why they say it's a leaf-shaped structure. You can kind of see that leaf shape here. And this little area here, this ligament, is what you're aiming for if you're going to do a needle cric. So it's a very, very tiny and thin structure. I'm sure you'll see it when you start working in the lab on this. It's a very tiny, tiny structure. And then remember we said that cricoid cartilage is the only one that's a solid ring. There's that ring. And then everything else behind it is C-shaped. Now, if you're wondering why it's C-shaped, what sits behind, remember I did this, what sits behind this trachea here? If you said the esophagus, you're correct. The esophagus sits back there. So if you've ever been chewing on a Dorito and you don't get it fully chewed up and you swallow it and you can feel it and it's stretching and you can feel it as it's descending down and you're like, oh, 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 oh. We have that a little bit of elasticity back here in those C-shaped rings. This is what allows that to pass without us getting hung up. So that actually is a huge benefit to us that they're C-shaped, because it does allow for that esophagus to expand and allow the food to pass down without getting obstructed. I know it's going to show you a lot of other features here, your corniculate, your cuneiform cartilage. It's really kind of hard to make them out here. It's a lot easier in this picture up here. So when you're looking at the vocal cords, you have the true vocal cords, which are white in color, and then you have the false vocal cords, and the false vocal cords are kind of pink. And you'll see you have these different cartilages, the corniculate and the cuneiform cartilage. And I'm going to go ahead and make a note right now, so I'm going to pause the video because I want to put in something for you guys. Hold on. Now hopefully I'll remember what that note means, but I'm going to try to put in a video that you guys can watch on the side. It's not going to be anything you have to watch, but you can actually see when this soul decides to intubate himself with a camera, so you can see as he's going down and he starts talking and singing and doing various things. So you're able to see those cartilages move and how they control the vocal cords to allow sound to be brought through. So this is what you're seeing. When you go to intubate, you should see that intubation tube fall into that vocal cords, the two true vocal cords. You should be able to see that. The viewpoint you never want to see as a medic is this. If you're needing to intubate somebody and you look down in there and the vocal cords are slammed shut, you got some work to do. I'm just going to leave it at that. And this is what I was talking about. You've got that C-shaped cartilage, and you have that little muscular band on the back. There's your esophagus. So it allows for that Dorito that was too big that we shouldn't have swallowed, but we got in a big hurry, and it gives it that little bit of extra space so that it can stretch and push it down through. So it's kind of convenient. You'll also notice some other concepts here. You have these little mucus glands, and they sit inside the respiratory epithelium. And that actually helps to catch debris and helps, there's little cilia in there that helps sweep that nasty junk up and get it out of our system. And this doesn't do a really good picture. I'm not even going to talk about it because it's going to be messed up. Not even going to mention it. There's that cilia that I was talking about. So this is what it looks like in under the microscope. And you have these little columnar epithelium that have the cilia, and the cilia's whole job is to sit and sweep all the mucus and the junk that we take in from the environment, whether it be dust or anything like that we've taken in from the environment. It's going to trap it with the help of these little goblet cells that secrete mucus, and that helps to kind of push it back out. Now, if you're a smoker, if you are a smoker and you smoke, the cilia actually will become stunned as a result of that smoke, and they will stop moving. So if you've ever went to bed and woke up in the morning and you've coughed a whole bunch and you're like, oh God, there's so much crap, I'm bringing up all this crap, it's because in the middle of the night you didn't get up and smoke. So it allows the cilia to start waking up, and then they go to work overnight trying to kick out all the crap that you've put into them during the day. So that's why you have that. And we mentioned that you have the primary and secondary and tertiary bronchus, and then you get, or bronchi, bronchioles as you move down. And then you get into this terminal area, or the alveoli. And this is just another good picture to show you those smooth muscle bands. So when you have bronchoconstriction, these are the guys that are squishing down and causing all the trouble. And you have those little elastic fibers that kind of help hold the alveoli in their place and allow them to recoil like they should. So just another good picture. And this one shows you what it looks like under an electron microscope. Again, you're kind of seeing the alveoli as they're popped open and the ability for you to get gas exchange here. This just shows off what I had mentioned before about having one cell in thickness, and that allows you to get that gas exchange that you need, provided we don't have any disease problems. Now we're going to focus on respiratory physiology. And what is the definition of ventilation? So ventilation is defined as the mechanical process of bringing air into and out of the lungs, not to be confused with respiration. So ventilation is the mechanical process of bringing air in and out of the lungs. So we're talking about, all the muscles that have to contract and the diaphragm that contracts, all of that stuff happens. That's what ventilation is. And I really like this side view picture because I never understood. I'm like, how can a diaphragm that looks like a big, most pictures show it like this here, where you've got this like bell shape, and you're like, how can that contract and pull down? I don't understand how that can pull down. My brain just could not process that. Well, I like this picture here because I think this does a better job of explaining it. So your diaphragm is connected up front here, like at the xiphoid process, okay? And it is also connected at the back here around your lumbar vertebrae. So when the diaphragm is contracting, it's really not this weird picture we've always seen. These muscles contract, and when they contract, it pulls down this way. So you can see how it kind of pulls in this direction. And as it does that, the other things that take place is all that musculature, those intercostal muscles, the sternocleidomastoids of the neck, those scalenes, all of that stuff will pull that rib cage up. And when it pulls the rib cage up, it gives you more volume, more space for the lungs to expand out. So that's what we're really looking at. So when you think about ventilation, and I think about it in the next slide, when you think about ventilation, it's a mechanical process of bringing air into and out of the lungs. It is the mechanical process. And there's some very specific thoughts we have. You have inhalation and you have exhalation. So let's look at those. In normal ventilation, and I want to put a big fat asterisk on this word, normal. That's the key word, normal. In normal ventilation, inhalation is active. Why is it active? All of those muscles are having to be drawn up, so they're contracting. Does that, a muscle contraction, does that require energy? Does it require energy? If you said yes, you are correct. So if the muscle is contracting, it requires energy. So that inhalation is considered an active process. When you exhale, the muscles let go and everything falls back to normal. So exhalation is considered passive. Inhalation active, exhalation is passive. Now that's the way it should happen. Like you see up here, you have this nice pretty look. And I say this is what it should be until you have diseases like emphysema. Now I'd mentioned this before, and we kind of start looking at it in depth. So in the alveoli of someone who has emphysema, you have lost those elastic bands that kind of wrap around and keep the alveoli back in their normal position. So they lose their elasticity and the alveoli get blown out here and they look really terrible, right? So this is what emphysema looks like. As a result, they have a barrel chest and it becomes very hard for them to exhale. So in someone with emphysema, not only are they using the normal amount of metabolism they would have to use in order to inhale, but now they're having to use all the muscles of their diaphragm to exhale. And so that means that exhalation has went from being passive to now we're having to use muscles. It requires metabolism. We're making it an active process. So think about your emphysema patients. They have a big barrel chest, but they're emaciated. They're emaciated because they're having to use twice the metabolism of a healthy person. They're having to use twice the metabolism just to breathe. that they didn't have to do before. So they have very emaciated limbs, but they have this big barrel chest. They have a very thin, emaciated abdomen, all because they're having to do twice the metabolism in order to breathe, or exhale in this case, because they got to push the air back out. Now this is the slide that kind of helps tie all this together. In an x-ray, and I'm going to teach you a little bit about x-rays really quickly. So in an x-ray of a chest, you should see the diaphragm. The diaphragm should have kind of this bell-shaped appearance. We know it has bell-shaped appearance. This is what it should look like. You should be able to see the spinal column in the back. Now this person does have a bit of, they're either laying funny or they've got a little bit of curvature in the spine, because you can kind of see this. You can see the vertebrae here in the back. The other thing that you'll notice is that you have the structure of the heart. So we know that the heart sits more to the left side. So this is the left side. So you see a little bit more of the heart over here, and you'll see a little bit here on the right. Just a little bit, not a whole lot. But that heart should be, and it's part of that mediastinum, should be in the center of the chest wall, okay? Now, this is what a normal x-ray should look like, and you should not have anything weird. I know you got the little green highlights here, don't pay attention to that, but you should have pretty clear vision of the rib cage. You should be able to see air. You know, it should all look like it's supposed to. This is abnormal. Let me tell you how you know it's abnormal. Look at the shape of the diaphragm. The diaphragm is no longer kind of arched up here in a bow. It is now flattened out. So that tells you that it's a barrel chest. Here's the other thing you will notice. Look at the way the ribs appear here on the edge and compare them to this. This is as stretched out as a rib cage can get. This is a comfortable rib cage, is kind of chill. The other thing you'll notice here is that the area is very darkened. You will have more of a lighter gray appearance. This is okay. Now don't get stupid light gray, because that can be disease of another issue. But this is really, whenever you see black, it's air. So this is really hyperinflated, and that's the point we're getting at here. This chest wall is someone with emphysema. They have a hyperinflated chest. You can tell because the rib cage are stretched out as far as they can go. The diaphragm is flattened, and you have a whole lot of black. So that's how you know that this one over here is a barrel chest emphysema patient. And incidentally, if you have someone who is going through an asthma attack, and they have a severe asthma attack, it can very much look like this in an x-ray if you're able to catch it quick enough. But we don't want to play with that. We just want to fix them, so we give them albuterol. Now, the next slide is going to show you what this chest wall looks like from the side. So in the side view of a barrel chest, and it's in both. Let me see here. I'm trying to see past, my picture is in the wrong spot. When I go to do the edit, I'll fix it. But you've got the side view here, and you can also see the barreling out of that chest here. Look how dark it is. Very dark. This is your heart structure. Okay, so there's your heart, there's your vertebrae. This one has a little bit of kyphosis to it, so you get the little bit of the arch in the back, so you got some kyphosis. But the diaphragm is flattened out. Again, you can see the diaphragm is flattened out, and you can see that the rib cage is as pressed tight as it can get. This one is also a barrel chest. Again, you got the flattening out. I think this might be the same picture as the previous slide. I'm not altogether sure. But anyway, this is the side view of a barrel chest. And with emphysema, again, older, they're thin, they have severe shortness of breath, they have that really emaciated appearance. Because they're using twice the metabolism that they would, because the exhalation has become an active process. So you can kind of see here again, it's hyperinflated, you got a flat diaphragm, all those things kind of pull together and create this. The other thing with emphysema is our body responds to that by creating more red blood cells. So they have a condition called poly, meaning many, cyte, having cell, in the bloodstream. So polycythemia, and that means they have an increased red blood cell production. Now, some other examples that impede airflow include ARDS, pulmonary fibrosis, and pneumothorax. So ARDS is adult respiratory distress syndrome. They don't fully understand the pathophysiology behind this, why it happens or doesn't happen. They have been able to tie it to chest wall trauma as a higher risk for developing ARDS. It carries a very high mortality rate because it's very hard to correct. Pulmonary fibrosis is the eventual stiffening of the pulmonary system, and they're not able to ventilate as well. And of course, a pneumothorax, you have air that's being introduced into the thoracic cavity, and because it's escaping the lung. Now, the best way for me to tell anyone how to remember what tidal volume should be, and tidal volume can either be written as a V with a little t or a big T with a little v. Either way, it means tidal volume. So if you see a machine or some sort of lab work and it has VT like that or TV, we're talking about tidal volume. The average tidal volume should be about 500 to 600 milliliters. The easiest way for you to remember this is to look at your pop bottle. Your pop bottle is about 600 milliliters. That's how much you should take on a normal breath. So I want you to let that sink in for a second. Because what's the one thing that we do with our patients if they stop breathing? We use a bag valve mask. And when we use that bag valve mask holds far more than the tidal volume that should be going into our lungs. That bag valve mask can hold up to 1,600 milliliters or more than 1 liter it can hold. We don't want to squeeze that bag and completely deflate the bag, and people make that mistake. This is a very simple medical device that can have very, very damaging effects if it's not handled properly. If we should overinflate because we are sitting there and we're crushing that bag and we're squishing it down and we're putting in that full 1,600 milliliter tidal volume, if we do that, the expansion of the lungs will actually pinch off the inferior vena cava. And when you pinch off the inferior vena cava, guess what that does to your cardiac output? It reduces your cardiac output. And if you do that, that means you're losing your preload because the blood isn't able to dump in. So you've lost the preload. And if you don't have preload, are you going to have a good effective pump? No. And if you ever get the chance to stick your hand in the middle, we used to take pig lungs, and we would have someone hold their hands around it like rib cage. So you're going to have that little bit of inflation and deflation that you would expect. And if you have someone that hyperinflates it and you've got the other person holding the ribs, the lungs are being inflated and your hand is the heart and you're trying to pump your hand. As those lungs get really, really full because they're overinflated, you will find it very hard to pump your fist in there. That's what your heart's having to work against. It's awful. So we definitely can cause severe damage and kill our patients if we're not careful with just that simple device. So this is it for this lecture. We'll come back to the next lecture. We'll finish this out for respiratory review. Thanks.